I'll just do a brief kind of intro first. So these are not on your slides, so don't be concerned that you don't have any of this. This is not tested material. And then we will go into the actual first lecture for today. But I wanted to first take the opportunity to introduce myself. So if I haven't mentioned before, I'm Dr. Garrett Ward. I am a family medicine physician who kind of had an unusual path in medicine. That ultimately got me to here. So first of all, I went to the Uniformed Services University, so USIS, so Military's Medical School. Started there in 2006 and then graduated in 2010. Thought I wanted to be a surgeon, so I wanted to fix people right. And so I went to a surgery internship at Naval Medical Center at Portsmouth there in Norfolk, Virginia. Was there. And, took the beatings that are typical of surgery. Thought I wanted to go back into it, but the Navy ultimately at the time had us all go out to the fleet to get some kind of utilization tour out of us. So I became a flight surgeon and deployed on the Abraham Lincoln Carrier Airlane 2 in support of OEF missions back in 2012. Finished out my 2-year tour there in Lemoore, California, and then went to Oceana Naval Air Station in Virginia Beach, and did another tour as a flight surgeon in order for me to get a master's in health administration. I kind of had learned in my first tour is on administrative boards in hospitals, there are no medical providers. It's always the brainiacs, the money folks who make decisions based on money, not on patients, right? And I realized that as providers, we don't have the ability to communicate like an administrator. So that's why we don't get put on these boards to make decisions that affect patient care, right? So I went to get my MHA, my Master's in Health Admin, through University of Southern California. Graduated with that in 2 years. And then thought I was going to apply to residency, and the Navy had bigger ideas for me and transferred me down to the Marines to fill a critical gap, fill it there. Was there for 2 years, and really during that time is when I learned I actually really enjoyed primary care. Took care of a lot of patients, got to actually establish good patient-physician relationships, and really enjoyed that process. So I decided I actually want to be a family medicine physician, applied, and got accepted at the program up in Fort Belvoir, which is a great tri-service program. If any of you are going to Belvoir, it's a great training opportunity. We have a lot of IPAP students rotate with us, and they got a great training experience just like we did. So once I finished residency, of course this was during COVID, I went out to Guam, and I was a senior medical officer on board one of our submarine tenders out there, which was a very interesting and humbling experience in a lot of ways, because we think that, okay, I'm on a U.S. territorial island, I probably have all the medical needs I have. Well, guess what we didn't have on the island? A cardiologist. So we struggled to take care of our patients in that regard, because it entailed us either having to be really patient to wait for that cardiologist, a cardiologist from Japan to come down once every 4 months, or we had to medevac them back to Hawaii in order to get simple things done. So that was humbling. But then that brought me to here, and I've actually loved being here, loved teaching. Usually we're very hesitant taking on the cardiology portion of instruction, but actually with working through it, I've actually really enjoyed this topic, and I wish I had the ability to actually teach cardiology before I was actually sent out to an area that didn't have a cardiologist. So, but then part of that, I just wanted to become a better teacher. So USIS actually offers a teaching certificate in health professions education. I'm finishing that up. By the end of this month, I'll have that certification done. So kind of, you can see it's a continual learning process. Just because you get through IPAP doesn't mean that you are done with your training. You're not done with your learning. It's a continual process to improve yourself. So. But one thing I want to have you think about is, well, why are you here? So why are you here in IPAP? Was it for you to study 12 hours a day, sitting in these desks every day? In my opinion, probably not, right? But is this more along the lines of what you picture as what brought you to IPAP, what brought you to want to be a PA, or was this more what you were thinking of? Is this your motivation? Is this your why on why you're here in IPAP? It's hard to lose sight when you're in these classrooms for as long as you are, especially junior semester, I get it. But don't forget the why, because that's what's going to keep you going through this program. That's what's going to keep you going through the times where it feels like you're just getting gut punched. So remember this, to get a picture of that why, put it there, keep that motivation up. Because I can tell you, on the other end of this is one, just a blip in time, and two, it's worth it. So remember that why. But I want to kind of show you something, and I want to kind of use this as a highlight. Remember, what's the bigger picture in everything that you are studying, okay? So hopefully the audio works. If not, I can explain what to do.
And its test. How many pockets does the peak light make? The answer, 13. But didn't even me walking there.
So that was a good ad for looking out for bicycles and stuff. But I use that as a point to illustrate. We are throwing so much data at you that all your focus is how do I memorize all of this? How do I keep all of this straight? But really, when you focus on that, you start to lose, well, what's the bigger picture of all of this information that I am learning? What is this significant? What is this slight difference in this pathology compared to this? Why is that such a significant difference? So I ask you, as you're studying this material, please focus on what is the significance instead of just memorizing the tiny detail. Because I can tell you, a lot of my test questions, a lot of the PACRAT, a lot of the PANTS questions are going to be asking you about the significance of that data. I'm not going to ask you, what is 1 plus 1, right? Why is 1 plus 1 significant to what we do? So why is cardiology significant to you? Are you training, or do you have motivations right now to be a cardiothoracic PA or be a cardiac PA? I can probably tell 99% of you the answer is no, right? Hopefully maybe I can get one of you by the end of this class to be motivated to be a cardiology PA. But when you look at the data, this is why, even for primary care, it's important for you to learn the cardiovascular system. So first of all, this is data from the CDC from 2019 that looked at all outpatient encounters in the United States. Now, 2019 is the most recent set of data. You can imagine it is very time consuming to kind of collect all of this data from all the visits and everything like that. So that's why this is the most recent. But you can see in a primary care clinic, 10.3% of visits were cardiovascular related. 10.3%. So if you're seeing 20 patients a day, at least 2 of your patients that you see that day are going to be cardiovascular related. But this isn't immune to just the primary care. Let's look at ER visits in the United States. A little easier to compile the data from ER visits because probably hospitals that have ERs use electronic health records, so it's a lot easier to do data mining on electronic things versus paper, right? And you can see this data is from 2022. This is the most recent that they have published. But this is also at the height of COVID, and you can still see 3.6% of ER visits in the United States were cardiovascular related. Now you look underneath it, pulmonary or respiratory system, it's 8.9%. And I suspect that COVID was a significant portion of that 8.9%. But you can see the cardiovascular system is an important thing. And it's important for you from a patient care standpoint because a large portion of your patients you're going to take care of have a cardiovascular disease. Now, probably more immediate to your concern is, how is this going to help me on the PANTS? So according to the 2025 PANTS blueprint, that the version of the PANTS that you all will be taking, 11% of your test is going to be cardiovascular related. The largest portion of your PANTS is going to be based on the information you're going to learn in this class. What's nice is the blueprint then also breaks it down on what pathologies you need to be comfortable talking about and being tested on. And you can see that 11% is pretty exhaustive. It's 2 slides, one full page of things that we're going to have you understand enough to be tested on. My hope is that during this class, this is not how it's going to be interpreted in cardiology. So hopefully you are not going to have to put up with what our military leaders and our ally leaders had to put up with the briefing of the intricacies and difficulties of managing the Afghanistan war environment. This was an actual slide presented to our leaders and to our allies' military leaders. So hopefully it won't be like that. But that being said, how are we going to achieve this mission? So first of all, this is going to be, I'm going to give 4 tests during this portion of the class. EKG is rolled into this, so really this is a 5-test class. Your grade is based on the 5 tests, not just my 4 tests and not just EKG. So hopefully that will help you. So if you don't do as well on one test, there are enough other tests to kind of make up for that. But we're going to do 4 blocks, about 80 hours of instruction, so I'm sorry you're going to put up with me for that long. But our textbooks are going to be mostly these 2. So Lilly is going to be our main one, with kind of backup is the Washington Manual for Cardiology. It used to be this. So we were able to condense it down to this. So, this is written, one of the writers is Fauci, of the infamous Fauci. But you'll see there are things I'm going to have to use a little bit of that textbook. You'll see some of our algorithms kind of were based on that, but for the most part, the Lilly is going to be our main textbook. So if there are questions, that is available in the library for you to look at. Before we get started, do I have any questions about how we're going to do this? Okay. All right. So we'll start our first lecture. The first 3 lectures of this block are going to be review. Okay. I do this for a couple of reasons. One, in adult education, they teach us that we need to bring back experiences that we can then build on to kind of solidify points, right? So let me bring back some experiences from freshman semester. Let me bring back some experiences from even prior to PA school, and hopefully we can then build off of that so it helps with your understanding. The second reason I do this is maybe you didn't quite understand a concept in freshman semester. Maybe you didn't quite understand something from sophomore semester. Let's revisit that. Let's solidify, let's clarify any confusion, because we are going to go through a whirlwind in this class, and if I don't have this solidified, this foundational knowledge solidified, it's going to be very difficult with the subsequent blocks. So bear with me with the first 3 lectures. If it's all review and you understand all of this stuff, bear with me, because at the end of our 4th lecture of this block, it will be newer material. So, So we're going to talk first on this lecture about the anatomy and the physiology of the heart, okay, or of the cardiovascular system. So the cardiovascular system in and of itself is this tightly regulated system that is so complex that not just one thing controls its function. It interacts with every other system in the body, and every other system of the body is going to interact with it somehow to guarantee that it is getting what it needs from the heart, from the cardiovascular system. So what does that look like? Hey, I'm exercising, my muscles are working hard, I need more oxygen, I need more nutrients to continue to function at this pace. Send me more blood. I just ate Thanksgiving dinner, I am really full, I need to digest the ton of food that I just ate. I need more blood going to the intestines to be able to absorb those nutrients out of the GI tract and then distribute to actually be utilized. All of those systems are going to regulate the heart and divert the blood to where it's needed most. And during the course of this class, we're going to talk about how that happens normally, but then we're also going to talk about it in abnormal states, what is going on, how that's impacting the heart's function and the blood distribution. So let's just kind of first talk about the heart, how it's arranged. So first of all, the way the heart sits, it's directly kind of in the center of the chest, substernal, but then it's rotated and then tilted back to the point where the most anterior structure is going to be your right ventricle. So if you take a blow to the sternum, steering wheel to the chest in a car accident, a ball, soccer ball gets kicked at you, hits you in the chest, the structure that's going to be most impacted is going to be your right ventricle. Your left atria is the most posterior structure because of that tilt and then that twist, that tilt backwards. So that twist and tilt backwards leaves the left atria to be the most posterior structure of the heart. It's bordered by a lot of other things. So you got your lungs, of course, on your right and your left. You got your diaphragm inferiorly, and then superiorly, you have like your mediastinum, so your great vessels and those types of things. And your heart sits there in the center of the chest, and it's stabilized by the pericardium. So what exactly is this pericardium? So it's two layers. Kind of looks like a halfway deflated balloon that the heart just kind of sits right on top of and kind of envelops the heart. But you have these two layers, the parietal pericardium, which is a thick fibrous layer that kind of attaches to all the other surrounding structures, maintaining that position of the heart in the center of the chest. And then you have the visceral pericardium, which is the innermost layer. And because you have these two layers, it now creates this little space which is filled with a little bit of pericardial fluid. And only about 10, maybe to 50 milliliters of pericardial fluid is there normally. Why is that important? That creates a frictionless environment for the heart to beat. What does friction do to work? Adds, it increases work or diminishes work, right? So if I am exhausting work, I'm exhausting effort in order just to contract, I'm losing function, right? So if I now create a frictionless environment, now I am not exhausting some effort, I'm not exhausting some work in order to just squeeze. So that's why this pericardial fluid, this small volume of pericardial fluid, is important to the body. Now, ultimately, the three main reasons that we have this pericardium is, one, just so that it maintains the location, so it limits that motion. Can you imagine if you are running and you don't have this layer to kind of maintain the position of the heart? The heart's going to be swinging around, right? What is that going to do to your output. It's going to disrupt that, right? So now you may be running and all of a sudden you're passing out because my heart is tilted, swung, or whatever in a way that now that outflow is obstructed, and now I'm not getting blood out of the heart up to the brain like I need to in order to maintain consciousness, right? So that's one of the main functions of the pericardium. Another role is this extreme dilation. So think of what happens to a balloon. I have it hooked up to a high pressure, air source. I'm going to put air in, it's going to expand, right? But I add more, all of a sudden it's going to pop, right? So the pericardium gives you an external barrier to kind of prevent that extreme dilation, so you're not stretching the heart so far that now, one, it ruptures, or two, it affects the function of the heart to the point where now you're not pumping any blood out because you're just, it's like a rubber band that's stretched too far. You lose that elasticity, you're going to lose that strength, you're going to lose that cardiac output if you get that extreme dilation. And then the final main role is a barrier from infection. How many times do we have pulmonary infections, whether viral or bacterial? Pretty common, right? We're coming up in cold and flu season. What is cold and flu season? It's viruses that affect the respiratory system. Well, what happens if that virus gets to the heart? Now you have inflammation, you have infection, you have all that stuff going on. That's going to then even make you sicker, right? Coxsackie virus, kind of a good example, hand, foot, and mouth disease. Annoying, highly contagious, right? But if it's just external, it's just on the skin, it's an annoyance, it's not necessarily going to kill you, right? But let me take that Coxsackie virus, and now let me put it in the heart. Now I have pericarditis, or I have myocarditis, so an inflammation, infection of the muscle. Now I'm disrupting the function of the heart, and now potentially a life-threatening disease. So hand, foot, and mouth, an annoyance, could kill you if it gets to the heart. And the pericardium helps maintain that barrier to decrease chances and likelihood of infections getting outside of the heart into the heart. Now let's kind of go in a little bit closer and actually talk about the layers of the heart itself. Okay, so there's three layers to the heart. The epicardium, so the outside layer, is basically the same thing as the visceral layer of the pericardium. Okay, so those two layers are the same thing. Working our way in, then you have the myocardium, which is the muscle layer of the heart. So this is where our function is, right? It's also where all of our other things, blood vessels, nervous system, all that stuff is located as well. And then you have the endocardium, which is the innermost layer. And the point of this is it keeps the blood, it keeps whatever is inside the chambers of the heart, inside the chambers, and they don't have a direct connection with the muscles of the heart. And the advantage of that is, one, the muscles of the heart aren't necessarily stealing all the oxygen out of the blood that's in the chambers first before it gets a chance to get out into the brain and all that kind of stuff. It regulates that oxygen diffusion, but it also keeps things that does happen to get into the blood, so infections, sepsis, those kinds of things, right? Bacteremia, it keeps that inside of the heart and less likely for it to infect the muscle of the heart, which then could lead to disruption of normal function of the heart. So the endocardial layer is of importance. The myocardium, there's really two components to it. So there's the contractile part, so the muscle part, the thing that actually squeezes. But then you also have the non-contractile portions, which are your conduction system, which you're learning about in EKG, right? They include your blood vessels that provide the oxygen, those nutrients, as well to the muscle to keep it functioning properly. And then you have the endocardium, which we talked about and why that is important. questions about that anatomy before we go on to the conduction system? Okay. So now I'm not going to talk about the conduction system to the level of EKG because I know you haven't been tested on EKG yet. So I don't want to add confusion. But I do want to talk about the anatomy of the EKG, or anatomy of the conduction system, to kind of help us understand how do we change an electrical impulse into a functional response. How do we get that change, right? So the conduction system itself is made up of the SA node, which we see here, right? This is where, in most folks in the normal functioning heart, those action potentials are being generated to organize that cardiac response, right? This is where the whole drive of the cardiac cycle should be coming from. When that action potential is generated in the SA node, it then will send the electrical impulse down through the internal pathways towards the AV node, okay? And as that is conducting down the internal pathway, that is when you are getting that atrial clip, or you're getting that squeeze of the atria. But this is only on the right atria, right? We have two atria. So how do we get that electrical impulse from the right atria to the left side of the heart? If we had to rely on just the myocyte to myocyte to myocyte conduction, you could potentially get to the point where the right ventricle is finished squeezing before the left atria even starts to squeeze. And you can see how that's going to create a problem, because now you have the left and the right side not working together at all. So the body has adapted to the point where now you have this other pathway that goes from the SA node, called the Bachmann's bundle, and it brings that impulse over to the left side to trigger that left atrial contraction. Which is why when you look at the P wave, it has the shape it is. Because the first part of that P wave is the right side contraction, but then the second half of that P wave is the left atria contract. And when you get like an atrial enlargement on one side over the other, you get that distortive kind of pattern on your EKG because it's impacting that conduction from the right to the left, or that squeeze of the right and the left atria. So we've got the action potential. It's at the AV node. You're going to get that brief pause to make sure that you're getting blood, as much blood as you can, from the atria and into the ventricles. And then the AV node is going to send down that impulse through the His bundles, the His system, the bundles, in order to coordinate that ventricular contraction. What is interesting, though, is these bundles up here in the septum, the interventricular septum, these are insulated to the point that you don't get a triggered response to that action potential being sent down. Why is that significant? Well, let's say you have a tube of toothpaste that's half filled, and I squeeze it in the middle. What's going to happen? Toothpaste is going to go up, and it's going to go down, right? How is that going to affect your output? Your output's going to go down, right? So with this being insulated in the septum, it's not until it comes down into the Purkinje system and you start to kind of loop back up from the apex out, that is where you start to finally get a response, a ventricular response to that contraction. So now I have an up and out squeeze. So all of that blood that's sitting in the ventricle is going to go one direction. And hopefully that one direction is out through the aortic or the pulmonary valve, depending on which side you're on. So you can see how well designed the heart is in order to promote efficiency with its function, right? But we talked about how the function of the heart is tightly regulated. And all these other systems are going to communicate and regulate the function of the heart to make sure that it gets what it needs. So how can we regulate the heart? There's three main ways that we can do this, where we're getting inputs to elicit a change in response to the function of the heart. The first one is this Bainbridge reflex. So as you're having more blood returning to the heart and that atria starts to stretch, you start to get increased volume to the atria, this is going to trigger the heart to beat fast. Kind of think of this as what you do in exercise, right? You're exercising, you're pumping your legs to get that blood out of the legs and back up to the heart. What is your body going to do? What's your heart rate going to do? It increases, right? We think of it, okay, just the need, the supply, whatever, the demand is up, so I need to supply more. But part of that also, that increase in heart rate, is I need to get rid of that extra volume that's returning to my heart before I overwhelm the pump, and now the pump stops working, right? So as the body, or as the atria stretches because it's getting all that increased volume of blood, I need to get rid of that blood before it backs up, so I'm going to increase the heart rate in order to do that. So that is the Bainbridge reflex. Then another way is just your simple breathing patterns, okay? So as you take a deep breath in, you create a negative pressure environment in the chest. What's going to happen with a normal flow, passive flow of fluids? You're going to go from the high pressure system, so your extremities, to your low pressure system, your chest, right? So as you take that breath in, you're increasing your venous return, more blood is coming back to the heart, and now I'm helping kind of circulate blood more efficiently. The opposite is true, where now I exhale, I now create a positive pressure environment, and now maybe that pressure in the chest is higher than the pressure in the extremities, so now that venous return actually slows down. It decreases. So just your normal respiratory cycle can impact the function of the heart. And then of course there's the autonomic nervous system, which is comprised of both the parasympathetic nervous system and the sympathetic nervous system. This is the regulatory system that we typically think of because this is your fight or flight or your rest and digest systems, right? So what does the autonomic nervous system do for the heart? First thing it will do is it will modify how fast we generate action potentials, which is going to result in changing the heart rate itself. If I don't need as many action potentials, like you all sitting here in this classroom, do you need to have your pulse at 100 beats per minute, or is 40 okay? Can I meet my minimum demand at 40? Kind of depends on your physical fitness level and all that kind of stuff. Lots of other things, yes, I know. But your body's going to regulate, so you're not wasting energy if you don't need it, right? Second way it's going to impact the function of the heart is it's going to determine, or it's going to impact how fast can this action potential get from point A to point B. So how fast can I conduct from the SA node down to the AV node? How long am I going to delay that AV node from sending the action potential down to the His-Purkinje system? How am I going to impact that conduction through the bundles? You can see in several different places it's going to affect that conduction speed. And then the last thing it does is contractility, so the strength of that actual contraction of the heart. It can regulate it to the point where it will make it a much stronger squeeze, or it can make it a lighter squeeze. And we'll see kind of how this works with both the sympathetic and the parasympathetics. So the sympathetics, it synapses on the SA node, it synapses on the atria, the AV node, and the ventricles. And recall that the sympathetic nervous system is your fight or flight, right? So if I fight or flight, I'm going to speed up my heart rate. I'm going to kind of get amped up, ready to go, right? So kind of think about that when you think of the heart and what we would expect to happen with this. So on the SA node where it synapses, probably what it's going to do is it's going to increase that rate of generating action potentials. So it's going to increase the heart rate if you're in a sinus rhythm, right? When it gets to the atria, it's going to do two things. It's going to increase the speed of that action potential going from the SA node to the AV node, but then it also is going to increase the strength of that atrial kick, so that squeeze. It's going to increase that, so you have more volume flowing from the atria and into the ventricle. When it synapses on the AV node, it's going to increase the speed of conduction in and out of the AV node. So you may not have quite as long of a pause to the AV node with this if you're in a highly stimulated sympathetic system versus a low or parasympathetic stimulated system. And then the sympathetic nervous system does synapse on the ventricle, and it's going to cause the ventricle to have one, a more powerful squeeze, so that contractility is going to go up, but it also is going to increase the speed of that action potential being conducted down the His and into the Purkinje systems to actually trigger that more powerful, effective squeeze. So you can see the impacts of the sympathetic nervous system to provide that fight or flight response. Now let's look at the parasympathetic nervous system, okay? So this is your rest and digest system. So kind of think about what that is and how that's going to impact the heart. It synapses on the SA node, so it's going to decrease the formation of action potentials. So it's going to decrease the heart rate in a sinus rhythm. On the atria, it's going to decrease that squeeze. It's also going to decrease that conduction from the SA node to the AV node. The AV node, it's going to slow down that conduction into and out of the AV node. So it's going to slow down that heart rate. But you'll see what's kind of different from the parasympathetic nervous system to the sympathetic nervous system is parasympathetic nervous system does not synapse on the ventricles. So now there is no system to slow conduction down through the His-Purkinje system. There is no system to slow down or to decrease the power of the squeeze. So you kind of go back to just the neutral, what is a normal squeeze for the ventricle. There's nothing that's going to then further diminish it. So we've been talking about action potential. So what exactly is an action potential? I know this is being presented to you in PhRMM. I am not going to test you on which phase of the action potential are we looking at. I'll tell you outright, I'm not going to do that. That's not really that significant to me. What is significant to me, though, is what are the ions that are important for these action potentials? Because later, when we start talking about arrhythmias, when we talk about like electrolyte disturbances, you'll see why that disturbance may be actually important to the cardiac system. So when we're looking at cardiac muscle, you can see the three ions or the three electrolytes that are important is sodium, calcium, and potassium, right? So those are your three things that are important to be able to actually have an action potential generated, so a depolarizing event, but then also to repolarize the cell to be ready for the next action potential to generate and then propagate down through the conduction system. So that's the cardiac muscle. Compare that to the pacemaker cells where, yeah, sodium may have a component to this action potential generation, but it's not as important and as minimal when compared to cardiac muscle. So really, in a pacemaker cell, so this pacemaker cells are your normal conduction electrical system. It's calcium and potassium that are important for the actual generation of that action potential and the propagation of that action potential from the SA node towards the AD node and then into the His-Purkinje system itself. So calcium, potassium for pacemaker cells. And why is this important for you to know and understand? Well, if I want to slow down somebody's heart rate, does it make sense if I have and develop a sodium channel blocker? Slow down the influx of sodium and stuff like that to depolarize a pacemaker cell? The answer is no, because a pacemaker cell is not reliant on sodium in order for that depolarizing event to occur. But calcium is. So does it make sense that I come up with a calcium channel blocker to slow down my heart rate? And the answer is yes, and guess what? We've done it. Your non-dihydropyridine calcium channel blockers, your diltiazem, your verapamil, do precisely that. It affects those calcium channels so it slows down the actual depolarizing of the pacemaker cells, which then leads to a slowing down of the heart rate. Does that make sense? Now let's start looking at the microscopic level. So you have a cardiac muscle, which is made up of a bunch of muscle fibers, which then can be broken down to a bunch of myofibrils, which then is made up of a bunch of sarcomeres, which is basically these actin and myosin interactions, these overlaps, in order to actually trigger a response. Now we talked about how calcium is important for the conduction and generation of action potential, but calcium is also vitally important for the actual functional response of the muscle itself to trigger a reaction. So calcium is super important to the heart. And what happens is calcium will get released when an action potential comes down through the conduction system, and it will trigger a release of calcium from like the sarcoplasmic reticulums, which you can kind of see as this like web-like structure that kind of surrounds the myocytes. And what happens is that calcium will bind right here on the troponin binding site on the actin filament, which then causes a conformational change of that filament so that now it exposes the binding sites for myosin to come up and attach, like you see kind of here, which then will lead to the little power flex moves that the myosin does. And what that does is you have two myosin on opposite sides, they flex in opposite directions. What happens is it pulls that actin filament towards each other. It decreases the length of the muscle, which then leads to a squeeze. Okay? So that's what's happening kind of at the microscopic level in order to have that actual squeeze. So calcium is important for the function of the muscle. Calcium is important for the generation of action potentials to trigger that actual muscle response. Does that make sense? So that's the microscopic level. Let's now look at the gross anatomy level and see what is happening to the anatomy to trigger this physiologic response. So I know you've studied the heart before, but we're going to follow the path of a deoxygenated red blood cell into the heart, through the heart, and out of the heart on the other side, okay? So, deoxygenated blood is going to come to the right atria via three ways: the superior vena cava, the inferior vena cava, and the coronary sinuses. So coronary sinuses are returning blood that went through the coronary arteries to perfuse and oxygenate the cardiac muscle itself, okay? So that deoxygenated blood is going to come back to the right atria. That deoxygenated blood is then going to pass through the right atria, through the tricuspid valve, and into the right ventricle during diastole. So that tricuspid valve is open during diastole. About 75% of the blood that you get into the ventricle occurs via a passive flow from the right atria to the left atria. So what does that mean? That just means that that flow is going from a high pressure system to the low pressure system. And it's just this passive flow through that open valve. Now, once that passive flow is occurring, it's going to get to the point where now you're losing pressure in the atria, but you're gaining pressure in the ventricle. And as those values start to equilibrate and become neutral to each other, that is when your atrial kick is going to happen. And that atrial kick is triggered by the SA node generating that action potential and triggering that atrial squeeze. And about 25% of your blood volume in the ventricle is going to occur because of that atrial kick, or that squeeze. And then that brings us into the right ventricle. And again, this is still deoxygenated blood. And what then happens is the ventricle is going to get filled. That action potential that was generated at the SA node is going to get to the AV node, and then it's going to send it down into the Purkinje system, and then trigger the ventricle to squeeze. When that ventricle starts to squeeze, that pressure starts to increase rapidly in the ventricle. It then exceeds the pressure of the atria, and that valve closes. That valve closing is important because I want a one-way flow of blood, right? I don't want my blood going back up into the atria because I'm losing volume, I'm losing efficiency, I'm losing function if I have it going in the wrong direction, okay? So I want that valve to close and allow the blood to go out through the pulmonic valve and into the lungs, where that blood now becomes oxygenated, and now it returns to the left atria, and it returns via the pulmonary veins to the left atria, and that blood then diffuses passively from the left atria into the left ventricle by passing through an open mitral valve during diastole. Then the atrial kick gets triggered. You get an active squeeze of the atria that then sends even more volume of blood from the left atria into the left atria to the left ventricle, and then that triggers the systole to start, where you now have that squeeze of the left ventricle to generate pressure to get that blood out of the left ventricle and into the aorta. What's kind of important is when we talk about preload and afterload, this is where that conversion occurs. I take what is there at the end of diastole, and now I send it out of the heart, and then circulate, perfuse the vital organs and everything like that. So, questions about the chambers of the heart? Let's go ahead and take 10 minutes. See you back at 9 o'clock.
you were taking it easy and didn't have something like that, what would you do?
Exam test. That's when we had exam weeks, so we got like 2 weeks of exams, and then we got like 3 or 4 exams. Okay, all right. Let's get back to our seats. So we talked about the chambers of the heart, but let's now focus on the actual valves of the heart. Because this is really the important structure in the heart to maintain that efficiency of work, right? This is what gives us that one directional flow of blood so that we are having that blood going into the heart, through the ventricle, or into the ventricle, and then out of the heart, into the lungs or into the aorta to be able to perfuse the vital organs. And we're going to talk about diseases in the future of when these valves don't function right, so we don't have that one directional flow. We'll talk about the implications of that. But for today's lecture, we're just going to talk about the anatomy of the valves themselves. So we're going to first start talking about the atrioventricular valves. So the valves between the atria and the ventricle, which are your mitral valve on the left side and your tricuspid valve on the right side. So tri meaning 3, right? It's 3 leaflets to the tricuspid valve. That's what gives you that integrity of flow from the right atria into the right ventricle and then out to the lungs. These are open during diastole and they close during systole. And it's the closure that is your S1 when you are auscultating the heart sounds. So this is your lub, is the actual closure of these valves. Kind of think of a door that's well maintained, it's oiled, it's lubricated, and stuff like that. Do you really hear that valve or that door open? Probably not, right? But do you hear it close? Yes, right? And that's what's happening to a normal heart, is you're hearing that closure of the valves when you auscultate. So S1 is the closure of your AV node. Another thing to kind of highlight that's important as far as the difference between the tricuspid valve and the mitral valve is in a normal mitral valve, there's 2 leaflets. Mitral valve is also sometimes called the bicuspid, bi meaning 2, right? So mitral valve has 2 leaflets to it normally. The semilunar valves, these are your aortic valve and your pulmonic valve. Both of these have 3 cusps to them, or 3 leaflets to them. They are open during systole. They close during diastole. And that's that closure that corresponds to the S2 or the dub that you hear during the auscultation of the cardiac cycle. Another thing that's kind of important is, so your aortic valve, it's got the 3 cusps, right? But your coronary artery openings, the ostia for the coronary arteries, are just above where these cusps or these leaflets are located. So we'll talk about that in a couple slides, why that's important to know that that's where those ostia, or that's where those openings for the coronary arteries are located. You have the papillary muscles. Do you have any airborne here? Okay. What's your risers do on your parachutes? So you kind of give you that tension so you don't have it where the parachute just kind of flips up and just flops in the breeze and then you're just falling, you know. It keeps that integrity of your parachute to slow you down, right? Your papillary muscles are similar to your risers on a parachute, where this gives you that counter tension to keep that valve closed. Because what will happen is before the ventricle starts to squeeze, you're going to have a little offshoot off the conduction system that's going to trigger a contraction of the papillary muscle. That's going to tense up and it's going to then give you that countertension as the pressure starts to build up in the ventricle. That valve leaflet, because of that tension, is not going to just flap open, and now you have blood regurgitating from the ventricle into the atria. So these papillary muscles are vitally important to maintain that unidirectional flow of blood out of the heart and into the lungs or into the aorta. But you can imagine if I have a pathology that affects the integrity, the strength of the papillary muscles. So for instance, I have a heart attack that kills the muscle in the papillary muscle. What are going to be the implications of losing this structure? My valve leaflet is just going to be flapping in the breeze, and now I have no integrity. I have no control, really, at this point on where that blood is going to go when the ventricle squeezes. Radiology. So we're going to talk about in 2 lectures, so lecture 3 of this block, we're going to talk about cardiac tests, and we'll talk more about radiology, but there's a reason the chest x-ray is so important in the evaluation of a cardiac suspected patient. And the reason is we can see so much of heart structures on that x-ray. It's more than just this white hazy blob under the sternum of the chest. There are things that you can garner from getting that chest x-ray. When we look at the anatomy on a plain film, an AP view with a lateral, on the AP part, what we are looking at, because of that kind of twist and then tilt back, is when you look at the right heart border, you can see the majority of your right heart border is either going to be your inferior vena cava, the right atria, and then the inferior vena cava. Your ventricles have nothing to do in a normal sized heart, have nothing to do with that right heart border. When we talk about our left heart border, you can see going from the bottom up, you can see it's our apex of the heart, our left ventricle, the left atrial appendage, not the left atria, just a portion of the atria, left atria, and then the pulmonary trunk, and then the aorta. So you can see what we are looking at when we look at just a simple AP view of the chest. When we look at a lateral view, you can see the most anterior structure is actually your right ventricle. So we said like your right ventricle is the most anterior structure based on the twist and tilt. So you can see that anterior surface is your ventricle. So if there is something wrong with the right ventricle, it's hypertrophy, you would expect to see that space larger, the haziness to be larger to the point where it's going to obscure kind of the normal clearing space that we see in a lateral view. When we look at the posterior surface, so yes, you got the aorta kind of coming down, but when we look at the actual heart structure itself, you can see you're looking at kind of here, left ventricle into your inferior vena cava a little bit in this little section here, but then you start getting your left atria. Right. So that's the kind of the structures that you're seeing on that plain film in a normal functioning heart or normal anatomical heart. The other thing is, it allows you to kind of see, is this heart normal sized? Is the anatomy enlarged for some reason or another? And you can do that by just taking the size of the heart and then moving it over to see if it's greater than 50% of the chest cavity. In this example, you can see, yes, it is. So this is a cardiomegaly, or this is an enlarged heart. Questions about radiologic anatomy or belt to valves? So now let's talk about the coronary arteries themselves. Okay. The coronary arteries are perfused during diastole. when do arteries normally perfuse? We normally think of it more of like a systolic kind of thing, right? But the coronary arteries is actually during diastole that they are perfused. And why is that? One is, what's the aortic valve doing during systole? It's open, right? The opening for those ostia are potentially being occluded or blocked based on that valve being open. So you're not getting perfusion into that. So that's one reason that you don't get perfusion during systole, or get minimal perfusion during systole. Second reason is, what's the cardiac muscle doing during systole? Say the ventricle cardiac muscle doing during systole? Squeezing, right? And we said that the blood vessels are part of that myocardium, but now I've got a strong muscle squeezing on what potentially are wee tiny vessels, depending on where you're at. What is that going to do to the flow of blood during systole if I have giant muscles squeezing and including those vessels? You're not going to get flow, right? So does it make sense that if we had a systolic perfusion of the coronary arteries, we may be setting ourselves up for failure, because you're not going to get that perfusion. So that means then I need that perfusion to occur with oxygenated blood during a period of rest, which is diastole. And that's when perfusion happens. It also is a lower pressure perfusion, which is why, like, if you have somebody who has a low diastolic pressure, we become concerned about, because we may not be perfusing the heart. When we have a low systolic pressure, we're concerned about the perfusion of vital organs, right? But a diastolic low perfusion or pressure, we're concerned about low perfusion of the heart muscle itself. So what coronary arteries do we have? So let's start on the left side first. So this would be the left, off the left coronary cusp. You have, first it starts with the left main artery, left main coronary artery, and then this divides into the left anterior descending and the left circumflex artery. And in a typical person, there's certain structures that are perfused by these arteries. So when you have a heart attack that affects the perfusion in that artery, we expect certain things to happen. So let's focus on the left anterior descending artery. So what is perfused by the left anterior? We've got our bundle branches. So what's that going to do to your convection system if we knock out your bundle branches? The bulk of your left ventricle, I'm killing the muscle of the left ventricle, the majority of the left ventricle. What's going to happen by that? All of a sudden, I'm not generating a squeeze, or at least a very powerful squeeze, to be able to overcome systolic blood pressures, to be able to get blood out of the ventricle, out of the heart, and into the aorta, into our vital organs, right? So this is why the left anterior descending is known as the widowmaker, because if you have a sudden occlusion of this artery, you're knocking out the majority of your left ventricle. And you're not going to be able to generate a cardiac output to maintain life. The left circumflex, on the other hand, it tends to perfuse the lateral and part of the posterior wall. So if you get a occlusion of the left circumflex, yes, there are some structures that are going to be knocked out and you're going to have a decreased squeeze and stuff, but maybe not as bad of an impact on the cardiac output as if we lost the left anterior perfusion territory. However, 25% of individuals, their SA node is perfused by the circumflex artery. So if I knock out the SA node, what's that going to do? So we can't just assume things. There are anatomical variations that are normal that could result in significant deficits. Most of the time, we don't think about the right coronary artery because it's not the common one, but it is an artery, it is a coronary artery, and it does have a significant function to it. So the right coronary artery comes off of the right coronary cusp and through the right coronary ostia. But if you were to have a perfusion deficit in the right coronary artery, the majority of patients, you're going to lose your SA node, you're going to lose your AV node, you're going to lose the function of your right ventricle, your right atria, and in a large portion of patients, your posterior side is going to be impacted. So imagine the geographic region, but also the important structures that are going to be impacted with a perfusion deficit in this artery, and what is the functional impacts going to be to that. And then posterior descending artery, kind of a codominant circulation of like right coronaries and the left circumflex kind of work together to kind of perfuse this area. So you may have, if you have the right coronary, you may still have some function of the posterior because you're getting that circulation through the left circumflex, or vice versa. So, all that to say, this is the end result of all of that. This is a tightly regulated, coordinated response leading to the bringing of blood in, the oxygenation of that blood, the sending of that oxygenated blood out and into the vital organs in order to support and sustain life. We'll finish our lecture talking about physiology. Okay, physiology is now that measurement of function. And that's important to understand because when we try to assess in pathologies where that function is disrupted, what is the impact going to be? So the role of the heart is to be that pump, to be able to generate that cardiac output, to circulate blood to our vital organs to oxygenate and provide the nutrients necessary for them to be able to do their function. So the measurement to be able to truly assess that function is known as cardiac output. And you can see in the formula here, cardiac output is made up of your stroke volume, and you multiply that by your heart rate. Okay? That's cardiac output. That's how you calculate cardiac output. Stroke volume times heart rate. Where your stroke volume is the volume of blood that is ejected out of the heart or out of the ventricle with each systolic squeeze. Okay. Normally, it measures about 46 liters per minute, but there are things we talk about how this is a regulated response, or this is a regulated function. So how do we regulate that cardiac output? How do we increase our cardiac output in demand in periods of high demand? How do we decrease that cardiac output in periods of low demand? So we're not wasting energy, we're not wasting effort to support excessive needs. So the way we do that is actually changing the heart rate, so we can slow the heart rate down or speed it up. But we can also impact the stroke volume, where the stroke volume is the measurement of what your end diastolic volume is, so the amount of blood that is there in the ventricle ready to squeeze, or ready to flow out of the heart, and then we subtract what the volume is that's left in the heart at the end of systole. So it's just a simple subtraction problem. So how much volume did I have at the beginning? How much volume did I have at the end? That value, that result is how much blood was sent out of the heart after that squeeze. And what's easy is we can then use this as simple math to figure out what our cardiac output actually is. So we'll do an example. So we'll say our end diastolic volume is 120. So that's the amount of volume we had to be able to be squeezed out in the first place. And our end systolic volume is 50. So 120 minus 50 is 70, right? So my stroke volume is 70. To calculate my cardiac output, I now multiply that by heart rate, and we'll say that that's 70 beats per minute. This is just an example. So 70 times 70, and we cancel out the common factors, and we get that our cardiac cycle in this example is 4,900 milliliters per minute, or 4.9 liters per minute. Okay. So that's how you calculate cardiac output. But I was talking about how we regulate it, right? So you can see kind of based on this, okay, cardiac output, we said was stroke volume multiplied by your heart rate, but your stroke volume is made up of your preload, your contractility, and your afterload. And we're going to look at each one of these factors individually to explain how that value itself can impact that stroke volume. So we'll start off with preload first. When we talk about preload, we could be talking about it being your end diastolic volume, or we can talk about it as your end diastolic pressure, okay? So it could be volume, it could be pressure. And we talk about it in the different pathologies, particularly in like block 3, where there are distortions and abnormalities to your preload. The best way to measure this is to do a left heart catheterization, but that's a pretty invasive procedure. So we tend to get estimations because they're less invasive. The means to be able to get an estimation are less invasive. But if we absolutely needed to know what our preload was, unfortunately it requires a pretty invasive procedure to measure that. But there are 5 things that contribute to your preload, okay? The first is, well, what's our venous return? How much blood are we bringing back up to the heart to be able to circulate out, okay? So if I have decreased venous return, so I'm sleeping and I'm not moving, okay, you're gonna have reduced preload because you don't have that blood volume coming back to the heart. The atrial contraction. So we talked about how about 25% of your preload is from that atrial kick or that atrial contraction. Let's say we have a cardiac condition like atrial fibrillation, where I don't have that atrial kick. I'm potentially losing 25% of what I should have simply because I don't have that squeeze. So now I'm solely relying on the passive flow of blood from the right atria into the right ventricle, or left atria into the left ventricle. Then there is the next value is the resistance of the valves. So valves should open and close with very little effort. But if I have a disease process that makes that valve stiff, now I'm having to exert effort just to get that thing to open. I'm wasting work. So I'm going to reduce my flow, unfortunately, and that's going to impact your preload. The next value is your ventricular compliance. So how willing is that ventricle to stretch to be able to accommodate that volume? If I have a balloon, it's going to be stretched out, right? It's going to stretch out to accept that volume if I'm blowing air in, or if I'm filling it up with water, if I'm making water balloons, it's going to stretch out. Well, let's say we have somebody who has had multiple heart attacks and a large portion of their left ventricle is scar tissue. Is that scar tissue going to stretch out to take on that volume? The answer is no. So now I have decreased compliance. So now I'm not going to have a large volume of blood being able to come into that ventricle to be able to be squeezed out and sent to the aorta or sent to the lungs, depending on your side. The final factor is your heart rate. This is not the heart rate itself, because you may be wondering, well, now I'm using heart rate twice in my calculation for cardiac output. The heart rate on this is how many beats per minute do you have, and how much diastolic time do I have? If that flow, this is your end diastolic volume or your end diastolic pressure, right? if I have a fast heart rate that's going 180 beats per minute, my diastolic filling time is going to shrink. So I'm not going to have much time to allow for blood to flow from the atria and into the ventricle. So it's going to result in a decreased preload because I don't have that, I simply just don't have that time in that cardiac cycle to get blood from the atria to the ventricle. Now the inverse is true, where if I have a slow heart rate, now I have an increased diastolic filling time. I'm now allowing maximal amounts of blood to flow from the atria and into the ventricle, which is going to increase my preload. So I'm going to have that increased volume there at the end of diastole to be able to get pumped out of the heart. Okay, so it's not heart rate just beats per minute. It's actually more what's your diastolic filling time. Does that make sense? Let's move on now to the second factor that impacts your stroke volume, and that's your contractility. So how forceful is that squeeze, that ventricular squeeze, to get blood out of the ventricle and into the aorta or into the lungs? And there's lots of things inherent into your body that can regulate this, like your adrenal nervous system and your catecholamines. But there are medications that we can give to our patients to also factor into this. And I know some of these you may not have talked about yet in pharm, but things like dobutamine and dopamine, we'll talk about those when we talk about heart failure stuff. Caffeine, of course everybody has caffeine in their system right now, right? We probably have an over-reliance on caffeine. But unfortunately it does have an impact on your heart rate, heartbeat, which means then you are increasing your stroke volume. So there are medications or substances that can increase your contractility. The opposite is true too, where we have medications to decrease your contractility. So things like beta blockers, calcium channel blockers. We can give these to our patients who have excessive contractility. Or these are side effects of giving these medications. So would we want to give one of these medications to a patient who is suffering from heart failure, who has a very weak contraction to begin with? No. The answer is probably no, right? We're just going to exacerbate their condition. And we'll talk about indications of when some of these would be given to patients and when they should not be given to patients in block 3. Our last factor that impacts stroke volume is afterload. This is a complicated equation. I don't expect you to memorize this. If you're an engineer, you may know this as Laplace law. Fortunately, in clinical medicine, we basically can narrow this down or simplify this to blood pressure. So what is the blood pressure of the patient? That is your afterload. The afterload is what is the pressure that the heart has to work against to get blood circulating out. So if I have somebody who has a blood pressure of 105/60, you can imagine it's not going to take much effort to get blood circulating. So I only have to generate a systolic of 106 or a diastolic of 61 in order to overcome that pressure to get blood circulating, right? But if I have somebody who has a blood pressure of 200/110, now I have to generate at least a pressure of 201 systolic and a diastolic of 111 in order to be able to get that circulation and maintain that circulation of blood out of the heart. So afterload actually has an inverse impact on your stroke volume. So the higher your afterload, it lowers your stroke volume. The higher your preload, the higher your stroke volume. The higher your contractility, the higher, higher your contractility, the higher your stroke volume is. So, but afterload has this inverse relationship because this is the force that the heart has to overcome to be able to get blood circulating out. So what factors affect your afterload that could increase it or decrease it? Well, one would be just simply the vascular resistance. So what's their blood pressure? Is the vessels constricted or are they dilated? Are they willing to take that volume or are they providing a resistance to flow? That's one factor. The second factor is what's the pressure in the aorta or what's the pressure in the lungs, in the pulmonary arteries, that will have that direct impact on that actual flow out of the right and left ventricle. And then, of course, there's valvular diseases. So what is the resistance that the valve adds to that afterload in order to resist the opening of the valve to get that blood circulating? And then the other one is the mitral and tricuspid valve. If they don't maintain that unidirectional flow integrity, and now you're having blood that's backing up and going into the atria, you're losing function, you're losing work, and you're losing efficiency of getting that blood out. And that will affect the afterload itself. Because then the other thing that's going to happen is that blood that refluxed back into the atria, well, in the next cardiac cycle, it's going to come right back to the ventricle, and now you potentially are overwhelming the ventricle. You have this excess volume present. There are some other things that can impact the function of the heart. So alcohol, especially excessive alcohol, is cardiotoxic. And we'll talk about situations where excess alcohol can actually cause pretty severe cardiac pathologies. Other illicit substances can do it, impact the heart. And then, other critical kind of things like acidosis and ischemia and those kinds of things. So that was cardiac output. That was complex, but that is the actual true measurement of function of the heart. But to be able to calculate a lot of that, it requires a lot of invasive tests. Do we want to potentially kill 5% of our patients undergoing cardiac evaluations simply because we want to get an accurate assessment of cardiac output? The answer is no. How many of you have ever had an echocardiogram done on you? Just an ultrasound, right? Great. The reason we're doing that is because we're trying to assess your function. Now let's say that you're going to go to a left heart catheterization instead of that ultrasound or that echo to be able to assess your function. 5% of you died with the procedure. Risk benefits? Probably not there, right? So because we realize that this could be a problem if we're killing 5% of our patients undergoing cardiac evaluations, let's come up with an alternative to be able to get a rough estimate of the function of the heart. And that is your ejection fraction. And the ejection fraction is simply what is your stroke volume divided by your end diastolic volume. And what ultimately happens is this tells me what is the percentage of blood that is ejected out of the heart with each squeeze. Now, it's a percentage. It's not an actual precise volume. Okay. So we're not saying you had 70 milliliters ejected out of the heart. What we're saying is you had 70% of the blood that was in the heart ejected with that cardiac cycle. Okay. So that's what ejection fraction gives us. But we can get it from an echocardiogram. So the most common way is the echocardiogram. If we, again, wanted to get a true and accurate, then we're having to do an invasive test, such as cardiac catheterization. But because we can just simply put an ultrasound probe on the chest surface and get this, we would prefer to do this way instead of potentially killing you. So what does that mean? Well, ejection fraction does not equal stroke volume, so please do not confuse the two, okay? Ejection fraction is your stroke volume divided by your end diastolic volume, but we said your stroke volume is your end diastolic volume minus your end systolic volume. So the equation then gets simplified to what is the product of your end diastolic volume minus your end systolic volume. Divide that by your end diastolic volume, because that gives you that percentage. Okay. So that is how you calculate that ejection fraction. And you'll see this when you go to do a cardiology rotation and you're watching a cardiologist actually reading an echocardiogram. What they'll do is they'll pause the image at the end of diastole. They'll measure the cavity of the left ventricle, and then they'll pause it again at the end of systole, and then they'll get another measurement of the volume of the cavity, and then that will give you your ejection fraction. So you can see this when you get to phase 2 when you're doing a cardiology rotation. Please go into the room with the cardiologist who's reading echoes, and they can show you some pretty cool things. So let's finish up this lecture by talking about pressure loops. So what exactly physiologically is going on in the heart every time you have a squeeze of the heart? And I apologize that this might be small, but we'll see. We'll work through this, and hopefully it'll make a little more sense as to what is going on. So we're going to start with diastole, okay? So we said that diastole starts with the closure of the aortic and the pulmonic valves, right? So what's happening when that pressure, or when that closure occurs and when that diastole starts? Well, you still have the ventricle relaxing, okay? That closure of those valves doesn't mean that the ventricle is fully relaxed. There still is some pressure in the, ventricle. So the ventricle is still relaxing, and what you'll see is there's going to be this rapid drop in pressure in the left ventricle. But because you have aortic or pulmonic valve closed, and you still have the tricuspid or the mitral valve closed, there is no change in the volume at all in the ventricle. There's nowhere for that blood to go to, so that volume stays the same as you continue to get this relaxation of the ventricle. Eventually, you're going to get to the point where now the atrial pressures are higher than the ventricle pressure. And that is going to trigger that mitral valve or that tricuspid valve to open. And now I have an open valve to allow blood to flow from the atria into the ventricle, and you start to see this increase in volume. That's your x-axis, is your volume, so you're increasing that volume. But as that volume is accumulating and getting higher and higher and higher, your pressure in that ventricle starts to increase as well. So you start to see how the y-axis starts to change, and that's your pressure. Eventually, you're going to get to the point where now that pressure in the ventricle exceeds the pressure in the atria, and you're going to get a closure of the mitral valve and closure of the tricuspid valve. And that's what this point here is. So this is your end diastolic pressure, and that's your end diastolic volume. So that's your preload. Okay? Well, the ventricle starts to squeeze, but let's say that pressure at the beginning of systole is only 10. Is that pressure of 10 going to exceed the pressure of 100 on the other side of the aortic valve? No. So you're going to still have a closure. The aortic valve is still going to be closed, and the ventricle is going to start to squeeze. It's going to squeeze, but because no valve is open, you get no change in your volume. That pressure rapidly rises to the point where now that pressure in the ventricle exceeds the pressure in the aorta, or exceeds the pressure of the pulmonary artery, and now you get an opening of the aortic valve and the pulmonic valve. And now you start to have flow of blood out of the heart, which your pressure still is increasing because your ventricle is still squeezing, but you can see because that blood volume is leaving the heart, my volume starts to go in the negative direction on the x-axis. So I'm still kind of going positive in the y because my pressure is still increasing because that ventricle is still squeezing, but I'm starting to lose volume, and now I'm moving in the negative direction on the x-axis. Eventually, you're going to get to the point where now you've lost so much volume that the ventricle cannot maintain a pressure high enough to keep that aortic or that pulmonic valve open, and now you get a closure of the aortic valve and the pulmonic valve, and then diastole starts all over again. So does that make sense? Okay. So that's the normal cardiac cycle. But we talked about things that we can do to modify the stroke volume to change this cardiac cycle in order to achieve the desires we have, right? So let's look at modifying one of these variables to see what that impact is actually going to be on your overall stroke volume or stroke work. Okay. So this top left hand corner, this is a normal function without any other variable being modified. So this is kind of say your baseline. Let's say that we increase our preload. So we're increasing our end diastolic volume, we're increasing our end diastolic pressure, and you can see what ends up happening is, we said this part right here, that was your preload, right? I now shift that up and to the right a little bit, and now what ends up happening is I'm adding all this work, all this stroke volume to my cardiac cycle, simply because I increased my preload. Now let's look at if I increase my contractility, okay? I know I'm skipping the bottom left. We'll talk about that one next. But let's increase our contractility. So we're increasing the strength of our squeeze. So what ends up happening is because I'm able to increase my strength of squeeze, I'm able to continue and maintain a pressure to keep that aortic valve or that pulmonic valve open longer. So now I'm having more volume leaving the heart or leaving the ventricle. I'm increasing my cardiac output. I'm increasing my ejection fraction. And you can see now I'm adding all this stroke volume, all this work to my cardiac cycle. So I'm adding to it. Okay. So we talked about increased preload, we've talked about increased contractility, adding to stroke volume. But let's look at what happens when we increase our afterload. We said that increasing afterload has an inverse relationship to your stroke volume. So the higher your afterload, the decrease in your stroke volume. And this is why. If I have a higher pressure on, let's say, the other side of the aorta, I now have to generate a higher pressure just to open that valve. And you can see I'm starting to lose work here because I'm having to exert more of an effort to get that valve to open just to get a flow of blood out of the ventricle. I finally generate that pressure, I get that valve to open, and I'm losing my volume. But as I'm losing my volume, I'm also potentially losing some pressure to maintain that valve to be open. And what ends up happening is I have a premature closure of that aortic valve. So now I am losing all of this work here, simply because that afterload was increased. So does that make sense? How these three factors affect your stroke volume? And these are not done in isolation, so it's not like you can only increase your contractility and only increase your preload. You can have it where you're increasing your preload and your contractility to increase that cardiac output, or increase that stroke volume to increase that cardiac output. Okay. Same goes with, I can also increase my afterload it counteracts some of my increased contractility and increase in your preload. So, unfortunately, that does happen. There is a small caveat, and this concept is important because when we start talking about heart failure, this thing comes, Frank-Starling mechanism, or this Frank-Starling curve, becomes important to know because this explains why we see the disease process that we see in heart failure. And what Frank-Starling says is increasing preload is a good thing to a point. There is a point in time as that pressure curve starts to go up that all of a sudden you start to lose function. So you're going to increase your preload to a point and then it has to stop there or else you start to lose function. You kind of think of it, what happened is you take your rubber band and you stretch it out a little bit, right? It has that increase in elasticity. It's going to then respond, go back to normal, right? You're having a powerful kind of snapback. But now let me stretch it out too far to the point where now I'm decreasing its elasticity and I let go. It's not going to rebound to what it was before, right? I stretched it out to the point where now it's not going to rebound and you lose function. That's what happens in the heart. And what is happening at a microscopic level is when we talk about those actin and myosin fibrils and how they interact and stuff like that, as I stretch those things apart, I start to decrease the number of actin and myosin interactions. So I start to lose the number of power flexes happening. So I'm losing that strength of elasticity. And that's what Frank-Starling is saying is that preload, increasing preload is good, but to a point. Now, we'll finish this as the last slide, but you can see what's going to happen to your pressure curves if you increase your contractility or decrease it, okay? You're going to have, okay, if you have a more powerful squeeze, you would expect that the stroke volume is going to increase. Same goes with if I have something that decreases my contractility, I would have a decrease or drop in my volume or in my stroke volume with that. But again, there is a certain point where all of a sudden, let's say it's just hyperstimulated too much, you start to lose the effect of that increased contractility. So pretty complex things going on in the heart, which is why a lot of folks struggle with cardiology and understanding the pathologies behind what is going on because we don't have a good foundational knowledge of this physiologic principles that we just addressed. So, questions? This is our PANTS blueprint. Unfortunately, because this was a review, we didn't mark off anything on this. This will be, unfortunately, the case for two more lectures. We're not going to start marking off anything, but I promise you on our fourth lecture of this block, you're going to start to see some red lines striking through diseases. So bear with me for the next two lectures, and then we'll start marking things off. So.